welcome to today's deep dive.
Yeah.
You're joining us for an exploration into a space that we all possess, but we honestly rarely think about until something goes terribly wrong.
Yeah, it's a pretty hidden world.
Right, because when you look in the mirror, you probably see your face as just a single solid canvas. It's your identity, it's how you express emotion.
Absolutely.
But underneath that surface, your face is actually this incredibly complex, high-stakes puzzle. It's full of hollow caves, delicate electrical nerves, and high-pressure blood vessels, all just packed together in the tightest possible real estate.
It really is. I mean, it is arguably the most anatomically dense area of the human body. Everything that's vital to how you experience the physical world. So your vision, your airway, your ability to speak, chew, smell, it's all layered, literally millimeters apart.
Just separated by tissue that's as thin as paper.
Exactly.
Which brings us to our mission for this deep dive. I've been going through some really fascinating and frankly kind of terrifying excerpts from a highly specialized medical textbook. It's called Operative Otolaryngology Head and Neck Surgery.
Quite a mouthful.
Yeah, it is. But we're taking you straight behind the surgical drape today to decode a procedure known as the complete maxillectomy. We're going to look at how doctors actually remove these massive tumors from the face and sinuses, all while trying to preserve a patient's life, their sight, and their appearance.
And this specific procedure is just a profound intersection of mechanical engineering and human resilience. Reading through these surgical protocols, it gives us this clear window into what surgeons are weighing when they have to fundamentally dismantle and then rebuild the structural pillars of a person's face.
It's wild. So let's start by mapping out where this battle actually takes place. If you're listening to this right now, take a finger and just tap your cheekbones right below your eyes.
Right there.
Those hollow spaces vibrating under your skin, those are your maxillary sinuses. They're essentially empty caverns inside your skull.
Yeah, and those caverns are lined with this special tissue called the sinus and mucosa. Tumors can actually originate right there on that lining.
Okay.
But they can also act as hostile invaders. So a cancer could start on the roof of your mouth, the hard palate, and literally chew its way upward into the sinus.
Wow.
Or it can creep inward from the skin of your cheek, or even downward from the socket of your eye, or, and this is scary, extend from the base of the brain.
Man. So the textbook notes that squamous cell carcinoma is the most common malignant invader here, which is followed by adenocarcinomas. But the text throws in this really massive caveat about two specific types of cancer, which are lymphomas and plasmacytomas.
Right, the exceptions.
Yeah. The protocol dictates that if a patient has either of those in their sinuses, the surgeons do not operate at all. They just send them straight to radiation.
Yep, completely different pathway.
And I'm assuming that comes down to what those cancers are actually made of, right? Like squamous cells are structural, they're the physical lining of the sinus, so you just cut out a structural tumor. But a lymphoma is a cancer of the immune and lymphatic system.
Exactly. It's systemic.
Right.
That is the exact mechanism driving the decision. I mean, surgery is incredibly localized. You cut out the bad tissue, but because lymphomas are tied to the immune system and essentially, traffic through the body's fluid networks, taking a scalpel to the sinus just doesn't cure the root problem.
That makes total sense.
Plus, lymphomas and plasmacytomas are highly radiosensitive. So the radiation acts like a targeted wave that just melts those specific immune-based cancer cells away. You don't even need to dismantle the patient's facial skeleton.
Which is a huge relief for those patients, I'm sure.
Oh, definitely. But for squamous cell carcinomas, which build these really dense, invasive physical masses, surgical removal is absolutely the primary treatment paradigm.
So to visualize how these squamous cell tumors behave, I just keep picturing the maxillary sinus as this hidden room inside the walls of a house.
That's a really good way to think about it.
Because you don't actually know there's an infestation growing in there. Right? It's happening in the dark, totally behind the drywall.
And the early symptoms are incredibly deceptive for that very reason.
Yeah, I mean, you read the early warning signs and they literally sound like a mild winter cold.
Just nasal congestion.
Right, nasal congestion,
Yeah.
nosebleed, things you completely brush off as seasonal allergies. You only realize something is deeply wrong when the tumor grows so large, it actually starts pushing against the walls of that hidden room, making the drywall buckle.
And that's when things get serious.
Very. The late-stage symptoms are alarming. We're talking facial numbness, double vision, lockjaw, which the text calls trismus, or even abnormal tearing from the eye.
Yeah, and if you understand the anatomy, those alarming symptoms are actually highly specific distress signals. They basically tell the surgeon exactly which wall of the hidden room the tumor is breaking through.
Wait, really? Just from the symptoms?
Yeah. Take the abnormal tearing, for instance. If your eye won't stop crying, you might normally think, oh, it's an eye problem. But the tumor in the cheek has likely invaded the space called the pterygopalatine fossa.
The pterygopalatine fossa.
Right. You can think of this space as a microscopic electrical junction box that sits deep behind your cheek. Inside that box is the vidian nerve, which acts as the electrical wire controlling your tear glands.
Oh, wow.
So when the tumor crushes that junction box, the wire basically shorts out and the eye just starts tearing nonstop.
Okay, so a numb cheek would mean the tumor is crushing the nerve cables in the floor of the eye socket then.
Exactly.
And lockjaw means the tumor is broken through the back wall of the sinus and is literally physically jamming the gears of the chewing muscles in the jaw.
Precisely. The physical exam essentially allows the surgeon to sketch out the first rough map of the invasion just by observing what functions are broken.
That is fascinating. But if those symptoms are just the distress signals, how does the surgeon, actually look through the drywall to see how big the fire is before they start cutting?
Well, they rely heavily on imaging.
Right, the text outlines this highly choreographed preoperative imaging phase. They use CT scans specifically to map the bony boundaries. Then they use MRI for the soft tissue.
Which is crucial.
It makes sense because an MRI would show if the cancer is crawling along those delicate electrical nerve wires you mentioned, which the book calls perineural spread, or if it's, God forbid, extending up into the brain.
Yeah, you have to know that.
And finally, they run a peri scan to see if the cancer has jumped to the lymph nodes in the neck, which apparently happens up to 35% of the time with squamous cell.
That combination of imaging is completely non-negotiable. I mean, the CT gives you the architectural blueprint of the skull, the MRI shows you the soft living tissues, the brain, the eyes, the nerves.
The important stuff.
Right. You have to know exactly where the microscopic borders of the cancer are before you make a single cut.
I am totally with you on the high definition imaging.
Right.
But here's where the textbook really threw me for a loop.
Oh, yeah.
In this era of 3D MRIs that can highlight a single microscopic nerve fiber, the text highlights a concept called Longren's line. It's this imaginary geometric line drawn from the inner corner of the patient's eye down to the angle of their jaw.
Longren's line, yeah.
It says tumors in front of and below this line have a better prognosis. Tumors behind and above it have a worse one. It's have to push back here. Why are top-tier facial surgeons still relying on a simple imaginary line drawn across a patient's face to determine their fate? It feels so, primitive.
I know, it sounds totally archaic, but Longren's line is not like a diagnostic tool replacing an MRI. It is a universal shorthand for catastrophic risk.
Shorthand.
Yeah, it instantly synthesizes the geometry of human anatomy.
Because of what lives on the other side of that line, right?
Exactly. Imagine that line cutting diagonally through your head. If a tumor sits in front of and below the line, it is mostly chewing into the hard palate, the teeth, and the nasal cavity.
Right.
A surgeon has physical space to maneuver in the mouth to remove that tissue safely, but the second a tumor crosses Longren's line, moving upward and backward, just look at what sits there.
The brain.
The base of the skull, the optic nerve, the internal carotid artery pumping massive amounts of blood to the brain. When a tumor crosses that boundary, it drastically shifts the conversation that the surgical team needs to have with the patient.
I see. So once that line is drawn and the imaging is reviewed, the surgical team consults what looks like a renovation menu to choose their approach. The scale of the surgery completely depends on the damage.
Yep, there are several levels to it.
You have the infrastructure maxillectomy, which is basically replacing the floorboards, just taking out the hard palate and teeth. The superstructure maxillectomy takes the roof off, removing the facial skin and the floor of the eye socket.
Right, moving higher up.
Then the medial approach just takes the wall separating the sinus from the nose. And then you have the complete maxillectomy, which clears out the entire sinus, and the extended maxillectomy, where they're actually taking adjacent structures, like the skull base.
And this deep dive focuses on the complete maxillectomy.
Exactly.
Preparing for a complete maxillectomy requires an enormous multidisciplinary team. I mean, you are removing a massive structural component of the face, so you don't just have the head and neck oncologic surgeon surgeon.
Who else is in there?
You need a prosthodontist, who is essentially an architect for dental and facial prosthetics. You also need a microvascular surgeon on standby.
Oh, that's for the reconstructive free flaps, right?
Yes, exactly.
Where they actually harvest living tissue, like a piece of skin and muscle from the patient's thigh or forearm, along with its blood vessels, and physically plumb those vessels into the arteries of the neck under a microscope, just to rebuild the roof of the mouth.
It is a stunning feat of microsurgery.
Yeah.
And coordinating all these teams requires intense logistical planning. Even the airway management is incredibly complex.
Yeah, the text mentions that usually the anesthesiologist can just use a standard oral breathing tube taped to the opposite side of the mouth from the tumor. But if the patient has severe lockjaw, or if the surgeons need to remove huge sections of the soft palate at the back of the throat, they might need to perform an awake elective tracheostomy.
Which is pretty intense.
They literally place a breathing tube directly into a hole in the patient's neck before they even put them to sleep.
And putting a patient to sleep introduces a profoundly important ethical and psychological aspect of this text, which is the weight of informed consent.
Yeah, the textbook heavily emphasizes having a full, brutally honest discussion about hypothetical intraoperative worst-case scenarios.
You really have to.
I'm guessing this is because once the patient is unconscious and their face is opened up, the surgeon might find the MRI didn't show everything right. And you obviously cannot wake a patient up mid-surgery to ask if they're okay with losing their eye.
That is a harrowing reality. I mean, the imaging is good, but it is not perfect. The surgeon has to sit down with the patient beforehand and say, look, we plan to save your eye, but if we get in there and find the cancer has wrapped around your optic nerve, what are your wishes?
Wow.
Do we leave the cancer and risk it spreading to your brain, or do we take the eye? If the patient's wishes are documented beforehand, the surgeon can make swift, life-saving decisions on the table without hesitating.
It is a terrible hypothetical to discuss, but absolutely necessary. So, okay, the consent is signed, the team is assembled. What actually happens when the patient rolls into the operation room?
This is where it gets very mechanical.
The text gives us a step-by-step walkthrough, and the sheer mechanical carpentry of the setup is intense. First, they rotate the surgical table 180 degrees.
Right, they physically spin the bed so the patient's head is completely isolated from the anesthesia equipment. That gives the surgical team unobstructed 360-degree access to the skull.
Then they also perform a tarsorrhaphy, which means they literally sew the patient's eyelids shut.
That protects the cornea from getting scratched by instruments during the procedure.
At the end of the case, they wash the eyes with a balanced salt solution, so the harsh iodine betadine used to sterilize the skin doesn't blind them.
Exactly.
Then come the incisions. The senior author prefers a lateral rhinotomy cutting right along the junction where the bridge of the nose meets the cheek, because it apparently hides the scar and the natural shadows of the face.
It's a very clever cosmetic choice.
Or they might use a Weber-Ferguson incision, which essentially splits the upper lip and curves all the way up and around the eye. But once they peel back the soft tissue, this is where my mind was completely blown by the mechanics.
Because it shifts from delicate soft tissue work to basically heavy structural engineering.
It sounds exactly like a construction site. They're using a 1mm side cutting pencil drill to perform periorbital osteotomies, meaning they're actually drilling through the bone surrounding the eye socket.
Yes.
They use flat metal retractors to physically hold the eyeball and the brain out of the way of the drill bit. And then they use a motorized reciprocating saw to cut through the roof of the mouth. If you're picturing this, how do they use a violent, vibrating reciprocating saw millimeters from the brain without plunging through and shattering the skull?
It's the ultimate paradox of head and neck surgery, isn't it? You are wielding carpentry tools, drills, saws, chisels, but you are executing the movements with literal millimeter precision.
It's terrifying.
The secret is tactile feedback. A seasoned surgeon's hands are highly calibrated. As the saw blade moves through the bone, the surgeon can actually feel the density change. Yeah, the dense, thick bone of the palate feels very different from the paper-thin bone near the skull base. They know exactly how much pressure to apply, so the bone fractures perfectly along the line they've scored, rather than shattering unpredictably.
There's one crucial maneuver the text highlights that perfectly illustrates this need for mechanical control. It's the removal of the pterygoid plates.
Yeah.
These are essentially the final bony pillars at the very back of the skull, holding the upper jaw in place. The standard textbook way to break them is apparently to blindly shove a curved metal chisel behind the plates and, well, blindly strike it with a mallet to snap them off.
Which is terrifying.
Right. But the author of this specific text explicitly advises against that. They recommend a lateral approach, where you pull the jaw down and back to approach from the side.
And the rationale behind that lateral approach is just a masterclass in risk mitigation.
Because if you go from the side, you aren't just swinging a chisel in the dark.
Yep.
You can actually see and physically control the internal maxillary artery. If you use the blind chisel method and accidentally clip that artery, you trigger a massive blinding hemorrhage deep in the skull base that is incredibly difficult to stop. But by going laterally, they can palpate the artery, clamp it if necessary, and cleanly detach the bone.
Because blind dissection in this area of the body is just catastrophic. That lateral approach transforms a forceful, uncontrolled fracture into a visualized, deliberate release.
That makes total sense.
And speaking of deliberate foresight, the text notes a really fascinating detail regarding reconstruction. If they use that microvascular free flap we mentioned to rebuild the palate plumbing in new tissue from the leg, they routinely cut out the coronoid process of the lower jaw.
Taking out a healthy piece of the lower jaw, is that to stop the jaw from accidentally scarring and fusing to the newly built palate while it heals?
Exactly.
Because if those two surfaces scarred together, the patient's mouth would be permanently locked shut.
Right. That is exactly the mechanism. It is surgical chess. The surgeon is thinking months down the line, anticipating how the inflammatory healing process will cause tissues to shrink and stick together. Taking out that small piece of bone guarantees the patient will actually be able to open their mouth to eat and speak once the swelling goes down.
Wow. So, okay, the tumor is out, the structural mechanics are done, but the physical void left behind in the face is massive.
Yeah.
How does the surgeon ensure the microscopic cancer is actually gone, and how does the patient ever function again?
Well, this brings us to what might be the most agonizing part of the text, honestly, the microscopic margin dilemma.
Yeah, this is where the textbook forces us to confront the harsh statistical reality of surgical oncology. When they're closing up the face, they have to worry about immediate severe complications. Visual loss is a massive threat here.
Huge threat.
If post-surgical swelling causes the fluid pressure inside the eye socket to exceed 30 millimeters of mercury, it starts crushing the optic nerve. The text says they have to perform an emergent canthotomy and cantholysis, which means they take scissors and literally snip the tendons of the outer corners of the eyelids.
Right. Snipping those tendons acts as a release valve. It allows the eyeball to safely bulge forward out of the socket, relieving the crushing pressure behind it and saving the patient's sight.
But the bigger existential threat looming over all of this is the surgical margins. The gold standard of oncology is achieving negative margins, meaning you cut out the tumor and you also take 1 to 1.5 centimeters of completely clean, healthy tissue all the way around it to ensure no microscopic stray cells are left behind.
That's the ideal scenario.
Right, but the text reveals a devastating statistic. In 30% of open surgeries and 24% of endoscopic surgeries, residual microscopic cancer is left behind.
And the medical data is unequivocal on this. Leaving positive microscopic margins statistically crushes the patient's 5-year survival rates. It significantly increases the likelihood that the cancer will just roar back in the face or spread to distant organs.
But if the data definitively shows that leaving even microscopic cancer plummets a patient's chance of survival, why do it? Why wouldn't surgeons just keep cutting until they have that 1.5 centimeter clearance everywhere?
Because eventually the scalpel hits a wall. I mean, the surgeon leaves it behind because of what is sitting exactly 1.5 centimeters away.
Right.
You cannot take a 1.5 centimeter margin on the internal carotid artery. If you slice into that artery to get your clean margin, the patient bleeds out or suffers a massive fatal stroke right on the table.
Oh, God.
And you cannot take a 1.5 centimeter margin on the optic nerve without completely blinding the patient.
The text explicitly states that safe dissection of circumferential margins may often not be feasible. That is a really heavy admission in the surgical textbook.
It is. You are balancing the absolute necessity of removing the disease against the catastrophic cost of destroying the structures that make human life livable. It forces the surgeon to walk this agonizing tightrope between extending the quantity of life and preserving the quality of life.
It really reframes the entire procedure for you as the reader. It's not just about the technical skill of what you take out. It's about the excruciating moral and medical decisions about what you are forced to leave behind.
Exactly, which loops us entirely back to why why mapping out Ongren's line and having those heavy worst-case scenario conversations before the anesthesia takes effect is so vital. The patient has to be an active partner in deciding exactly where they want to draw the line between survival and sacrifice.
We have covered an immense amount of ground today. We started with stuffy nose, just a symptom mimicking a common cold. We moved to mapping conceptual risk boundaries across the human face with Ongren's line.
Quite a journey.
We stepped into an operating room where surgeons use reciprocating saws and pencil drills to disassemble the skull, all while relying on microscopic tactile feedback to navigate around the arteries that keep the brain alive. And we arrived at the ultimate high-stakes gamble of surgical margins, where a single millimeter dictates a patient's entire future.
It really highlights, better than almost anything else we could study, that the human face isn't just bone and skin. It is the most emotionally significant and anatomically unforgiving real estate we possess.
It truly is. And as we wrap up this deep dive, I want to leave you with one final thought to ponder, building on the prosthodontist we mentioned earlier. When a complete maxillectomy is over, and if the roof of the mouth has been rebuilt with tissue from the leg, the patient wakes up fitted with an obturate.
Right, the prosthetic.
Yeah, this is a custom molded piece of hard acrylic with metal clasps that wire onto their remaining teeth. It physically plugs the massive surgical void in their skull so that when they drink a glass of water, it doesn't immediately pour out of their nose. Think about what it means to actually heal from this. Every time that patient speaks to a loved one, every time they eat a meal, every time they look in the mirror, they are relying on a piece of molded plastic, acting as the literal floor of their nose and the roof of their mouth. It's one thing to survive the physical trauma of the cancer and the saws, but consider the profound, quiet psychological resilience it requires to wake up, accept that the hidden room behind your face has been torn open, and relearn how to be human.